Hi, everyone, and welcome to our session, Mental Health Matters. Thank you so much for joining us this morning and choosing to come see us. My name is Savannah Sellers. I'm a correspondent and anchor at NBC News, and here on stage, I am joined by Admiral Rachel Levine. She's the Assistant Secretary for Health for the U.S. Department of Health and Human Services. We also have Dr. Tom Insel, former director of the National Institute of Mental Health, and also the author of Healing, Our Path from Mental Illness to Mental Health. And we also have Dr. Damour, who I had the pleasure of having a conversation with last year here at this very festival. She's a psychologist and author of The Emotional Lives of Teenagers. Thank you all for joining us this morning. The purpose today, of course, is to dig in on the fact that we know that mental health matters. It seems like a good thing that we are talking about it a lot more. It seems like a good thing that we're talking about it more when it comes to our teenagers, our kids, also ourselves. But how does talking about it more and how does being more aware of it match up with how we are treating it, how we are able to treat it, what the access to care looks like, and what can be done to improve that? So first, I would love to just start with each of you. One word, a few words. Just what do you think the state of mental health care in our country is? Admiral, I'll start with you.
Well, I think the state of mental health care in the United States, particularly for young people, is slowly improving. Now, I'll have to tell you, I'm a positive and optimistic person, so I tend to look on the bright side of everything. And I think that young people are very challenged in the United States and globally from so many different factors, which I'm sure we'll get into. But it has been one of the priorities of the Biden-Harris administration and our Secretary Becerra, our Surgeon General, and others to address the mental health crisis in youth and throughout the lifespan with resources, with increasing in terms of the workforce, and many new programs, for example, the 988 hotline. So many different programs, and I think that it'll start to make a difference.
Tom?
Yeah, I would certainly second this idea that we have leadership that's leaned in like we haven't really seen since the 1960s. So this is an extraordinary moment in terms of federal leadership and in some states as well. I'm from California. Our governor has now, I think, put about $20 billion into mental health care and innovation for that. But Savannah, I think even at this point, I'd sort of like to just, for this audience, distinguish between mental health and mental health care. Too often in these conversations when we're talking about health or mental health, we immediately begin to talk about health care. And they're not the same thing. They get conflated very quickly. And I think it is important as we go into this conversation this morning that we think about what is happening within the care system, which is slowly evolving and shows some promise. Also, I think is very frustrating for a lot of people. But that's different than what's happening at the level of the population in terms of mental health. And I think Lisa will say a little bit more about this as well, particularly for kids.
Well, then I will. So I do think exactly the same thing. I think when we think about mental health care for teenagers, we're often saying, well, where are all the clinicians for teenagers? There are not enough clinicians for teenagers, which is true. But the longer I've worked in this field, the wider my understanding of what mental health care for teenagers looks like. And what it looks like is also things like making sure teens are getting enough sleep. That is highly correlated with mental health questions. Or making sure that teens are connected to an adult in their lives, right? A lot of kids are saved by their theater teacher. Or making sure that kids feel that they're doing purposeful things. One of the most wonderful findings that comes out of UCLA is what really helps kids thrive is to feel like someone's counting on them. So if we can widen the lens about what we consider a mental health intervention for teenagers, we can do a lot of good to care for a lot of teenagers and actually hopefully keep them from needing the clinical care that is in such short supply.
That leads me to ask about something that we just saw happen in the news this week. And this is such an interesting group of people, I think, to talk about what we saw happen with the Surgeon General, to call for these warning labels on social media. We don't know what will happen. There's not legislation in front of Congress yet, and it's not a unilateral decision that can be made. But Lisa, what you just said struck me because we talked a lot about this last year. And I think as someone who covers this a lot, as somebody who does the reporting myself or has correspondents on my show who does this, we're like, social media is so much of the problem. It's bad. And I think part of that's true. Part of it, like you just mentioned, is maybe the access to a screen period that means the lack of sleep, the content that you encounter, what you're choosing to follow. But of course, we know that it is like an X factor that entered the equation for young people that wasn't there before. I'd love to talk about how we think this could help, if it could make a difference. Admiral, I'll start with you. This is, of course, something within your organization that happened. What do you make of the potential for that to help and what we could see happen with that?
Well, so the Surgeon General and I work very closely together at HHS, and he really made a bold statement that with his op-ed and his call for a Surgeon General's warning, and really to highlight the challenges and the potential dangers of social media for young people, particularly younger teenagers. We'll see what happens with it because it requires an act of Congress to have that happen. But he certainly has brought this issue to the forefront again, where it kind of ebbs and flows in people's in terms of people's experience and how they're paying attention to it. So he certainly has caused a stir. He certainly has brought it to people's attention. There's a lot of discussion in the media, pro and con, a lot of discussion in the government, pro and con. And I think that that's a tremendously valuable thing. We have many other activities looking at this exact issue about social media and the impact on young people. There's an interagency group that's been looking at it, led by SAMHSA, and there's lots of people looking at this, but the Surgeon General has taken the lead and taken a bold step.
Lisa, what do you say?
So it needs to be regulated. Full stop. How and where and how that happens, not my department. But what is also in that op-ed were wonderful recommendations for parents right this minute. And that's what I run into all the time, that while we're trying to sort out how we regulate this thing, parents are like, but what do I do with my 13-year-old today? And so some of the wonderful recommendations were things like waiting until after middle school for social media. And I'll tell you why. At 14, which is the beginning of high school, kids have a neurological watershed that lets them be much more skeptical of what is put in front of them. So there's a reason to think in that way. Keeping it away from bedtimes, keeping technology away from meal times, and making sure that kids are not using time spent on social media, crowding it out, all of the great things that they're supposed to be doing instead, like sleeping, getting physical activity, seeing people in real life. So the recommendations within that op-ed are just spot on for what those of us who are sort of boots on the ground caring for kids and families can tell you makes a material difference in the day-to-day of caring for kids.
I feel like it's almost controversial to ask this as somebody who, especially when I was younger, suffered from severe anxiety, still certainly struggle with it, but was diagnosed with a full-on disorder when I was younger. Talking about it, being able to share my story, having other people come to me has helped. However, because we have this missing gap when it comes to access to care for so many people, is there any chance that talking about it so much, or that having it be on social media and kids kind of self-diagnosing, could make things worse? Tom, I'll direct that at you.
Well, we've seen examples of that with eating disorders, right? Where I think, you can argue that there's a positive side for marginalized populations to find connections on social media, and there's actually a positive opportunity there. But I think in some places, and I think for anorexia is probably the best example we have, what we've seen is it's also giving kids who have the wrong intentions an accelerant, so that what we see today compared to where we were a decade ago is kids lose weight faster and lose more weight and end up in a much more severe metabolic state than they would have a decade ago. All of that, I think, can be attributed to the sites that are available to tell you how to lose as much weight as quickly as possible. That's a problem. But I think you bring up a really interesting point, Savannah, which is that we've been so focused on reducing the stigma around mental health that I sometimes have this experience of being in a school where if you don't say you have a mental illness, you're not cool. You're just not like, that's, it's no longer, there's a recent paper out, something like In Praise of Stigma, which is probably not where we want to be, but there is this need to, I think, find the right balance. because we're at a point, and Lisa probably knows much more about this than I do, where this has become an identity for people, not an illness. It's really it's something that they're sort of drawn to, and it becomes how they define themselves. I'm not sure that's progress, but I'd love your thoughts about that.
Well, we are starting to see some data come in that well-meaning programs that focus a lot on talking with kids, using diagnostic language, explaining disorders, are not having the outcome that we're hoping for, that it's having unintended consequences, leaving some kids feeling worse. And we don't exactly know why, but we think some of it is we give them just enough information to feel worse, but not enough information to figure out what to do with it. So I do think it's important that we have incredible systems that are aware of when kids are suffering and how kids are suffering and catching them early. Much easier to care for kids if you catch things early. And at the same time, we must normalize distress as part of life. And I'm all for wellness. I have my questions about the wellness industry. I worry that the wellness industry has sold an idea that somewhere out there there's this emotional zen and you can get there if you do all the right things. And the upshot of that is that people who are living their lives and then teenagers who are living their teenage lives feel like they're doing something wrong if they don't feel good all the time. And so one of the ways we can be really helpful to adolescents and to the adults around them is to say, distress is an absolutely essential part of what it means to be human. It helps us grow, it helps us learn, it guides us, it gives us feedback. And on its own, psychological distress is not a mental health concern. You're sometimes supposed to be anxious. Of course you should feel sad. There's plenty to be stressed about that is the right response. And so the work, I think, is in helping make a more clean distinction between feeling expectable levels of distress and having a mental health concern, and the messaging on that has not been nearly as clear as it needs to be.
How hard is it to even message that when you're talking with individuals?
Well, so here's what I find when I talk with teenagers, and I do this all the time, that say, of course, I mean, your lives are complex, you're growing and changing so fast, that's inherently stressful. They are so relieved to hear it, and it almost breaks my heart how often teenagers follow up with me and say, it was just so great to hear that I'm allowed to get upset, or I'm allowed to feel unhappy. And I thought, okay, we've really misstepped here, if that's what kids are taking from this.
Yeah, I think I love this take on it, because it does get to this question of mental health, not always an issue for mental health care, but being able to communicate to kids that it's okay to feel lousy, it's okay to not be okay, but to also get to a point where they're being able to say that to each other. It doesn't have to come from us. And really, one of the places where I think we have missed in this entire mental health care response is to think that everything needs to fit into this mental health care system that we have, that has to have a CPT code with it, has to have a diagnosis with it, and therefore gets a regulated therapy. That actually might work okay for infectious diseases and for cardiovascular medicine and maybe diabetes sometimes. It's not the right model for so much of what we deal with in the mental health space, where what's really missing is community. I like to call it the 3 Ps, people, place, and purpose. That those are things that actually we don't do in our clinics, we don't do those in our hospitals, but that's really the essence of recovery and the essence of mental health for not only kids, but for adults. And there's a real opportunity, I think, for us to do that for each other.
Yeah.
Thank you. So I agree with what you're saying completely, and I think that we have to normalize the normal stresses of life for young people that they face and that we all face. Everybody has stress in their lives, whether it's their personal life or professional life, and the key is then how you cope with those stresses. And we need to, in addition to normalizing the stresses that young people have, to teach them not in a therapeutic way, I mean by parents and teachers and others in the community, ways to cope with the stresses that we all feel in life. And that can be in a million different ways. I mean, maybe it is through sports and athletics. Maybe it's through yoga and Tai Chi, maybe it's their pets, maybe it's their faith. There can be a million different ways, and it'll change over time, and sometimes you need a menu depending upon where you are and what you're doing. But I would tell young people is that, gee, when I find out when you don't have a lot of stress in your life, I'll let you know, except I'm 67 and it hasn't happened yet. That I know. So I think that young people do need that in their daily lives, in their community, in their school, and in their families. I wanted to get back just for a minute about the social influences on eating disorders. So I had the opportunity in my academic medicine practice at Penn State to start and run the eating disorder program there for many years, and saw many young people with anorexia nervosa, bulimia nervosa, binge eating disorder, and other eating disorders. And it is certainly multifactorial in terms of what can lead a young person down that road to have a clinical eating disorder. I think our culture plays a big part, and that has only gotten worse with media, with the electronic devices we have, with the social media and more. We used to talk about pro-Anna and pro-Mia websites 15 years ago, and that has just accelerated. But that's not the only factor. There are clearly other personal and social issues that young people have. Sometimes there's family dynamics, and there is a certain genetic component to the development of eating disorders as well. So it is really the perfect storm with all these multidimensional factors that can lead a young person down that road. But we were talking just beforehand, there are more young people with eating disorders than we've ever seen before. I last did clinical practice 10 years ago, and we were over full in the clinic, and they are bursting. And that's not just, in Penn State, that's throughout the country.
Well, and actually on that point, I think I'm very cautious about blaming social media for things. But I think on this one, on the eating disorders thing, one thing that makes me extraordinarily anxious about social media platforms are the algorithms. And what an algorithm does is it decides what's in your feed based on what you're looking at. Teenagers are vulnerable to norms. They are more shaped in their behavior by what they think everybody else is doing than little kids are or that adults are. And so one of the things I do really think happened, especially in the pandemic, is that kids who had time on their hands started doing a little searching, fitness, weight loss, even kind of benign seeming searches. And then their feed was flooded with image after image after image of ultra thin, ultra fit people. And that changes behavior in teens pretty readily, unfortunately. So that's in the worry corner. But then on the coping issue, and Rachel, I agree totally. It's not about distress, it's about coping. Like, distress is a done deal. So my favorite thing that I hear more than anything from teenagers about how they cope, it's music. All of your teenagers have playlists. Most of them have playlists with feelings names on them. And when they are upset, if they're sad, they go listen to the sad playlist. And we actually have data showing that this actually has a cathartic effect, helps move them through and out of it faster. This is as adaptive as anything we could ever hope for. And I'm watching teenagers do it constantly. It goes unrecognized, but instead we're like, oh, there they are on their phones. Right? And I'm like, no, but they're doing exactly what we would want them to do. So I also think we want to be really careful about uncoupling social media questions from things like phone questions. Those are not the same question. And I'm watching kids use their phones for all sorts of healthy things.
Yeah, I think that there really has to be a nuance to this that might get missed. We're so eager to demonize the one thing that we think is leading to a mental health crisis. It's a little more complicated, and I actually love that op-ed. I thought it really hit all the right points. But even in the op-ed, it pointed out that this is more complicated than a single issue, and we really will have to think through what are the elements that are going to require the most careful regulation, and how does one do that to get the endpoint that you want instead of some unintended consequence that we can't foresee.
When we talk about access to care, eating disorders is an interesting one, just in my personal reporting that I think is a really good example. I just did a lot of reporting on boys with eating disorders. And I was shocked to find out in that even until a couple of years ago, doctors didn't know how to diagnose young boys with eating disorders. In fact, to have an eating disorder, part of the criteria was looking at a menstrual cycle. You couldn't even get a diagnosis if you were a young boy, which gets at, I think, stigma. It gets at underserved communities. and not being able to access care that is necessary to solve a problem that may be one that does need help. That is true for marginalized communities of all kinds, minorities, yes. LGBTQ+. Admiral, I'll start with you on, are we making strides in providing that access to more people and to the people who need it most?
So we are making strides, and it is really one of the focuses of the efforts that we have at HHS is to really help communities that lack access to health care and lack access particularly to mental health care. And that would include the Black African American community, the Hispanic Latino community, the American Indian Alaska Native community, and then you mentioned the LGBTQI+ communities. And so there are specific initiatives through, for example, SAMHSA, the Substance Abuse Mental Health Service Administration, through HRSA, through the CDC, really targeting those disadvantaged communities and trying to increase access to care and increase the workforce that is necessary across all levels of mental health care in order to take care of them. One example I would use is 988. So the 988 hotline is a critical tool. Someone doesn't have to be suicidal to access 988, and there's a specific prompt 3, and it can be from call, chat, or text. Kids don't call, of course, because they always text or chat. They don't call people. To access trained counselors from the Trevor Project for LGBTQI+ youth. And there are other programs through many of the divisions at HHS to do exactly that, to increase access to mental health services for those communities.
How do you feel we're doing with access for certain communities? I saw you nodding when I mentioned boys and eating disorders.
I'm really worried about boys. I feel like we've had a big conversation about girls, and I feel like the questions we ask are very good at detecting distress in girls. We tend to ask questions about depression and anxiety. People report on those. Girls are more likely to suffer from those as how they express distress. Boys express distress in other ways that we're not doing as good a job of asking about. The eating disorder piece for boys, I'm very worried. They are getting ripped, bulked, very, very lean. They're coming in very late to the hospital because they don't look so small. They look bulked up, but nutritionally they're in terrible shape. I'm worried about boys around things like gambling, online gambling. This is huge and is not a topic. I'm worried about boys around feeling small in our culture or neglected in our culture. Some boys feel that way, and unfortunately there's a whole bunch of bad actors on social media who are really glad to give those boys a way to feel good about themselves at the expense of women. I think there's tremendous work to be done in this area, and I think our findings are only as good as our questions, and it's time for us to start to really expand the scope of the questions we're asking about adolescence in general. We've done a great job at detailing what's happening with girls.
We've been talking a lot now, as well as in society. I think there might be another panel going on right now that's about teens and mental health. I think social media and screens has probably had a fair amount to do with our concern over what's happening with that age group. What about adults? And is the conversation being so focused on teens and also being so focused on adults being the trusted adult, being the one who is there to stabilize those teens, coming at the expense of adult mental health? Tom, I'll start with you.
Yeah, I guess there's a lot of talk about the mental health crisis in this decade. And for me, it's really 3 crises. The one that we've been talking about is the youth mental health crisis. And that makes sense to talk about it because it's new and it's a change in the prevalence. We're seeing a lot more kids with a lot more problems. For the CDC data, it's girls more than boys, but I agree with you that boys will be the next big topic. The second bucket for me is the bucket of serious mental illness in adults. Those would be psychotic illnesses, schizophrenia, bipolar illness, severe depression, severe PTSD, severe OCD, the ones that are really disabling. And those are not massively increased in prevalence, but the outcomes are much worse than they've been. We're seeing really just terrible statistics about how people with those illnesses are faring. And I've been in this field for 50 years. For most of my career, we were doing better than we're doing now. So this is not a crisis of prevalence. This is a crisis of care. That's really damning. And that's an indictment about us, not about the illness or the greater society. And then there's a third bucket, which is the substance use disorder bucket, which is, again, a different kind of crisis, massive mortality, over 100,000 deaths. Extraordinary when you start to add these numbers up. The amount of mortality from these diseases of despair, deaths of despair. But the substance use disorder mortality problem is really driven, again, mostly by fentanyl and by having new substances that are far more deadly than the ones we've had in the past. So for adults, absolutely, big issues, terrible outcomes, more morbidity, more mortality than we've seen for decades. But there's also a lot more we can do there. I think we understand the problems better. I'll just add to something about the administration leaning in here. 988, I agree, is a big deal. But the thing that no one knows about is that during the last 3 years, we've taken this program called the Certified Community Behavioral Health Centers, CCBHC, sorry for the acronyms. But if you know the FQHC, the federally qualified health centers that are providing primary care across the country for all populations, particularly marginalized populations. The CCBHCs are the same thing now for people with serious mental illness and substance use disorder. It's a $10 billion program. We've not seen anything like this. A federally organized, federally funded program across the country. Amazing that no one talks about this, because this is bigger than what Kennedy did for the Community Mental Health Act. Far bigger. It's about 4 times the size. And yet it gets no attention. But that really is an attempt to provide access, as you were asking about, Savannah, for adults across the country through community-based organizations that have a whole new payment structure and have what's called whole person care as part of their requirements. It's really an amazing and exciting moment, largely funded by the bipartisan Safer Communities Act.
So thank you very much for emphasizing the CCBHCs. And you know, there's always acronyms in the federal government, so we just roll them off our tongues. But that is a tremendously important, innovative program run by SAMHSA. And really is providing care, as you mentioned, for adults with serious mental illness in a holistic way. One of the things they're doing at those is a different way of integration of physical and mental health. So, you know, we have a real emphasis on that integration between physical and mental health, which usually means putting mental health providers in clinics, in, for example, the community health centers. But CCBHCs, if I can get it right, has reverse integration. They put internal medicine physicians or family physicians or nurse practitioners in the behavioral health clinic, because for many of those people with serious mental illness, their home, their medical home is that mental health clinic. And so as opposed to having them go get their medical care someplace else, they have the medical provider built in. So that reverse integration is really quite innovative and creative. Thank you for mentioning that.
What does peer-to-peer help look like, and how effective can it be? I know that's something that the Biden administration has placed a focus on as well.
We are emphasizing peer-to-peer, and one example of that would be with the crisis of the disease of addiction. And so peer counselors have a tremendous history of being involved with helping people with addiction. And you're exactly right. You know, the overdose crisis is such a significant issue in the United States that we are looking to deal with the president's plan and our health strategy through HHS. And one very important aspect in terms of counseling for that is peer-to-peer, because that really has been shown, and there's a good evidence base of that helping. But that is necessary, but still not sufficient. And so we need to work on prevention, continued prevention of opioid and other substance use addiction, on harm reduction, particularly with distribution of naloxone and other overdose reversal agents, with evidence-based syringe service programs, fentanyl test strips, and more. Treatment, particularly medication for opioid use disorder, such as buprenorphine medications, and then that recovery aspect, and that is often where the peer-to-peer work is most valuable.
How do you think this helps with the clinician shortage?
peer-to-peer?
Oh, I think it makes an enormous difference. I mean, any of you who have participated in AA know what peer-to-peer could look like. We just haven't used that enough as in the healthcare system, and we don't pay for it. We're beginning to, and I think this is what is the great innovation of the last 3 or 4 years, is beginning to understand, and actually it goes to the question you asked before, Savannah. We're very focused as healthcare providers on access, but for mental health, the bigger problem is actually engagement. It's not access. Access is important, but about 50 to 60% of the people with mental disorders who could and should be in care, they don't seek care. They don't want it. They don't buy what we sell. And unlike what you see with infectious diseases or heart disease or cancer, the more severe the mental disorder, the less likely they're going to engage. So engagement is a really hard problem to solve. And this is where peers make a difference. Because as we know through AA, you can get people engaged through community. You can get people engaged through social support, social connection in a way that doesn't happen through a kind of hierarchical brick and mortar medical care system. It's a very powerful new opportunity for us. I think if we're serious about it, we've got to figure out how to pay for it, how to scale it, and how to ensure that it has the quality to be effective. But this is an extraordinarily high potential opportunity for us right now.
In just a few minutes, I'm going to open this up for questions, so get ready for that if anybody has any. Go ahead.
Yeah, on the peer-to-peer stuff for teenagers, there's some things I think to be said. So one is, I'm not a big fan of asking teenagers to take more care of one another. They're all working hard to do that already. What I have seen be extremely effective is to recognize that teenagers know who's suffering long before the adults know. And so when schools call me, as they often do, and say, we want to do a big health and wellness situation at our school, I'll say, that's great. Here's what I would recommend. Make sure that all of your students know that there are 5 things that if they are aware of themselves in a peer or themselves, they need to let an adult know. So depression/suicidality, eating disordered behavior, self-harm, out of control weekend behavior, high risk taking, and dangerous relationships. And do programming that makes sure that students know what these look like, have these clear, and then make sure that your students have ways to let adults know who they're worried about that they will actually use. And what I will say to schools is, you could have the greatest health and wellness programming in the world. If your students don't feel they can tell an adult which peer they're worried about, you've got nothing. You could have 0 health and wellness programming. But if your students are willing to come to a teacher and say, I am really worried about Molly, and here's what I'm worried about, you're in much better shape. So I think often when we think about peer-to-peer with teenagers, we think about educating teenagers about, the diagnostic universe. I think a much more targeted approach that recognizes how much they care about one another and how much they know about one another and how early they know about one another keeps us in a position where we catch the problem small. And that's, for me, where it's at.
To get tactical, how do you ensure that counselors, teachers, administrators at a school are the people that students want to go to?
Here's what I say to schools. Go get your 6 bluntest juniors in a room and say to them, if you were worried about Molly, would you tell an adult at this school why or why not? And work with whatever they have to tell you.
Wow.
Because it's the kids' network and the kids' beliefs about the trustworthiness of the adults that you're up against. And if you ask a teenager a straight question, they will give you a straight answer. And that's why I love them. So there are ways to make it happen, but adults have to be willing to work with teenagers, create systems that teenagers will use. And if adults are in earnest, teenagers want to help their friends.
There are some specific laws. I'll give you an example called Breeze Law to teach young people in schools about violence, dating violence, and it's named after Bree, who was killed by her boyfriend as a teenager, and it has funding through Congress for some specific education programs for young people about educating about domestic violence and dating violence. surveillance and teaching them the warning signs, both for themselves and also their friends.
Let me just put a footnote on this, because a lot of what's happening in the peer-to-peer space is now moving it online. So there are now a number of startups that are creating these massive online communities. I'm not going to name names, but the key here is having an adult in the room. So this has really been a problem, and I don't think we've been sensitive enough to it. It's not enough to simply give kids a place to vent. There has to be, in the way we've done this, is to use a credentialed therapist. You don't need many of them, but you do need to have somebody who actually has the training and knows what to worry about and knows what the resources are, who's part of that online community. We have like one therapist for 1,000 people in the community. That's enough. So it scales very nicely, but it is a real opportunity as we think about peer-to-peer to be able to think about, okay, it doesn't have to happen in a brick and mortar environment. It could actually happen at scale, and it could even happen globally. But it has to happen with a structure around it and with people who actually understand when you need to worry and when you need to intervene.
I want to get to questions within the next 3 or 4 minutes, but I'd love to just quickly hear from each of you. I'll start here. What gives you hope about, to put it as Tom did, both mental health, but mental health care also importantly?
Well, so as I mentioned, I'm a positive and optimistic person, and I absolutely have hope in the future. I mean, in terms of mental health and mental health care. In terms of mental health care, it comes from many of the programs that we've been talking about that we're working on in the federal government. But you need programs at the state and local level where the care is actually provided as well. In terms of mental health for youth, I have faith in youth. I mean, they're our future. And I also have spent my career with teenagers and find them so interesting and challenging and provocative, and it's so rewarding. And I have faith in youth, and I think they're our future. I think that they understand what the challenges are, and I think that with our help and guidance, they are up to it.
It's great to hear. Go ahead, Tom.
Oh, I'm hopeful. I mean, I don't think this is There are lots of hard problems in medicine. This is not one of the hard ones. We know what to do. We have stuff that works. People don't understand that, but we have medical treatments, we have psychological treatments, we now have sort of neuroscience-y treatments, and we have very effective rehabilitative, psychosocial rehabilitative interventions that really do work. The problem for us is we don't implement. We don't do the things that we know are really helpful, and we're not very good at that. So I'm hopeful that we can get past that because of two things. One is I think we're beginning to figure out that we do have to start paying for things in a different way, and so whether it's through parity or through new efforts through Medicaid, which really very exciting. I'm pretty hopeful about that. For the first time, as I said, we have the leadership we've never had in this space. I'm also hopeful because I think innovation is going to matter here. If you think about what is AI and generative AI about, it's largely about language and communication and sharing information. That's what we do in the world of psychotherapy, in the world of psychological treatments. It's also what we do for diagnosis. And I think that AI, even in its current form, can absolutely transform mental health care, mental health diagnosis, and improve outcomes at a much lower price point. So I think of all the areas of healthcare that are going to be changed by AI, this is the one that will be changed the most.
I'm going to pick up on that. I think technology gives us options we have not had before. From things as small as social media accounts for parents about raising teenagers, raising kids. I mean, instead of people having to find a clinician, get to an office, right? It's in their pocket. There's guidance, in sort of snackable, volume. And I think that's useful. And then one of the things that really has not gotten the press it deserves, prior to the pandemic, we psychologists, if you asked us if virtual healthcare was a good idea, we'd be like, oh, no, you cannot do it. You cannot do it. Okay, it turns out you can totally do it, right? And we have a national license in psychology now, which we have never had before.
Yeah.
And states are quickly legislating their way into it. I have this license. I can take care of people in almost any state in America, which I used to only be restricted to the state where I worked. Okay, what this means for things like rural communities, what this means for specialized care, and even if people are using virtual appointments in their own community. I'm in Cleveland, and I'm close with the folks down at Metro Health Hospitals. Their experience in the pandemic is that it was a dual experience. They lost a lot of the families they were caring for. Other families they were caring for were suddenly making it to all their appointments because they didn't have to take 3 buses to do it. That they were having virtual appointments, and the clinicians were seeing the true landscape of life at home for these families. So virtual clinical care is a total game changer and something that we can do a lot with.
Although I think we're just at the beginning. I agree with you, Lisa. I think, gosh, it's made it so much more convenient for people to get care. And we've seen huge increases, far fewer no-shows, which is great. But what we do in telehealth today looks a lot like what we did in brick and mortar 10 years ago. And I think where AI and where all the new tools are really going to be important is to create telehealth 2.0 so that you're collecting data in that telehealth session that's critical for decision support, for improving quality, for understanding whether someone's getting better or not in a very objective way. We have vocal biomarkers. We know how to do this. It's getting it in place. That hasn't happened yet, but that'll happen. And I think it'll happen much more quickly than we think.
Let's open it up to audience questions. We have some mic runners around. I'll start right back there.
Hello, thank you for being here. I'm really enjoying this conversation. I am a mother of 4 young adult teenagers, and one conversation that I hear a lot from them about is weed and the impact and that what they're seeing, the usage, particularly in boys. And my concern is the high level of THC and the lack of regulation around this. I think Vermont's the only state that regulates this right now. And it's leading to psychosis and other issues. And I'd just like to hear your viewpoint on that.
Start with me? Okay. I worry about this. I worry about this for the reasons that you were saying. One of the things I worry about the most is the lack of regulation around the advertising of availability of marijuana. Some of my favorite researchers have done beautiful work looking at the penetration of ads and or dispensaries with visible signage in a community. And the higher the penetration of that, the lower the age of experimentation for kids in that community.
Wow.
And so it gets back to the thing I worry about the most with teenagers is norms. What are the norms that we set? And I worry that, the question of legalizing or not legalizing weed is not my department. What I do worry about is we need to be really, really mindful of the norms that start to crop up around its use. Because for some kids, it's going to be really dangerous. And so the larger population of kids we have who turn to it, the more kids we have to worry about. We regulate the advertising of liquor, right? We regulate the advertising of a whole lot of things. But it is worrisome to me to be in states where it's legalized and you go down the highway and it's just billboard after billboard after billboard. That's a problem, and that's something we have, under other conditions, done something about.
We should worry about it for kids who are at risk for psychotic illnesses. It's not entirely clear that the THC by itself in a kid that doesn't have that genetic propensity is going to create psychosis. But I think the data, particularly the data from the UK, are very compelling that for some segment of the population, this is really a toxic drug and very dangerous in terms of psychosis as an outcome.
Yes, right over here.
I'm James Corbett at Nisham Health. We work with states and counties around the country in the space of crisis care. So as a start, thank you, Rachel, for your statement on syphilis, point of care testing. Recently, a very important issue. And Tom, thanks for your book on the 3 Ps and healing. Communities are using it around the country in crisis care. So my question's around crisis care and the importance of the SAMHSA guidelines. They're really important. They came out, but that's the theory of it. What I'm seeing is communities struggle with the practice of it. How do you roll that out, particularly in rural communities, as you mentioned? And then, places like LA where they thankfully put it in hospitals, state hospitals, so they got around some of the NIMBY issues. I'm seeing a lack of understanding of the full potential of it in communities like Santa Monica and others. So what's happening nationwide to help with the technical assistance these cities and communities need in crisis care? Someone to call, someone to go, and some place to respond. Right.
So I think that that is critical, and what you're pointing out, something that we certainly learned during the acute phase of the pandemic, is that public health really only works well when there's collaboration and coordination between community public health, state public health, and federal public health. And then you could say international public health, but right now with those three. And so I think the SAMHSA guidelines are really important. I think crisis care is critically important. We have seen many challenges in our emergency departments as patients with serious mental illness and crisis back up the emergency departments, and they're not getting the care they need, and then the emergency department can't provide care to other patients. And so it really is one piece of the puzzle, but we need to work collaboratively in terms of the crisis standards of care, having enough beds, but also levels of care, whether it is intensive outpatient programs, partial hospitalization programs, so that we can get our patients, particularly young people, out of the emergency department. And we need to coordinate and provide that technical assistance at the community level, the state level, and of course working with the federal government.
I'll go right over here, right in front of this gentleman. I know it looked like I had called on you.
I have a learning center in Miami-Dade where children who have learning disorders or autism also have mental health issues. And I thank you because I am not aware that this exists. And parents are not aware. And if I need a child to see a psychiatrist for the first referral, it's 6 months, $1,500. So there's a real racial divide here. And it's interesting, my families who come from Argentina tell me that they can see a good psychologist for $15 and have easy access. So is this something that, are we back still in our dark ages where it was a stigma to get mental health care, and maybe that's why there's not so much access? But it really concerns me.
I think one of the biggest issues is access, having enough providers, but also in terms of insurance coverage. And so that gets to the parity issue, which passed Congress decades ago, but we're still working really hard to implement that in terms of parity of physical health and mental health insurance coverage. And we want to make sure that people have that insurance coverage. So for a young person, there's really no reason why a young person in this country should not have insurance. Between Medicaid, between CHIP, between the marketplace, and then private insurance, we should try to make sure that all those kids have insurance, and that in addition to the physical health insurance, that they have the mental health insurance to be able to get paid for, so that it's not going to be perfect, but they're not going to pay $1,000 to see a qualified professional. So it's really all of that put together.
A lot of providers don't take insurance because they aren't paid well enough to do it, and that's all part of this fix. There will be a new parity rule that will be out in the coming weeks. Yep. You know more than I do about that. It will be, I think, high impact, and it will not be welcomed by a lot of the insurance companies.
Let's go right here, please. Thank you.
Just for context, I'm an emergency medicine physician. I spend a lot of my professional time in indigenous lands, so I suspect you know where this question is going to be. In a normal 12-hour shift, I'll see 20 patients. A half to two-thirds of them have SMIs, suicidality, or substance use disorders, and I am a diehard optimist, and I do not see a light at the end of the tunnel in indigenous care for mental health issues. Can you shed some light on where it's headed?
Sure. It is an absolute significant issue. I've had the opportunity in my position to go often with Director So of the Indian Health Service and go to the Navajo Nation, go to Alaska Native communities, go to Oklahoma, South Dakota, and many other places. And significant mental health challenges and particularly substance use challenges. We are working very hard to work with the Indian Health Service in terms of expanding care. There's lots of work with collaboration between Indian Health Service and SAMHSA on that, but it remains a significant issue, but it is an absolute priority to do that. I'll take the opportunity just to highlight the Public Health Service Commission Corps. That's the uniform I wear, which is 5,600 dedicated medical and public health professionals, and we have over 1,500 officers who work in the American Indian tribes for the Indian Health Service and Alaska Native tribes on these and other issues.
But I don't think it's going to be that different, even if you're in a community hospital almost anywhere in the country. This is a national issue. And the essence of it is we don't have the capacity. There just aren't the facilities for people to go to often. And we don't have the workforce. So we're going to have to think carefully about what that needs to look like. I'll point you to California, because in California we have said this isn't working and we're going to have to do something very different. Just did a bond for $6.7 billion to build the beds, to build the capacity back that was lost during the 1990s.
We are out of time. There are obviously a lot of hands, so I think we'll all sort of be around, and hopefully you'll be able to ask those questions. Thank you all so much. What an engaging and wonderful conversation. I appreciate it.